extra-pulmonary or outside lung NECs for a substantial number of patients who are in need of therapeutic advances. However, there is a ray of hope.
This podcast is supported by an independent educational grant from Boehringer Ingelheim.
Hello, everybody. Today we will be discussing a very unique subset of neuroendocrine oncology called high-grade, poorly differentiated neuroendocrine carcinomas. And I have a very esteemed colleague who have spent a significant amount of time advocating for neuroendocrine carcinoma patients, Ms. Susan Plummer.
Hi, my name is Susan Meckler-Plummer, and I am a nurse. I've been a nurse my entire career. I started in oncology when my husband was diagnosed 13 years ago. So I've been working with neuroendocrine carcinoma patients since 2013.
My little journey in high-grade neuroendocrine carcinoma started when I was getting trained with Dr. Lowell Anthony at University of Kentucky. I was seeing lots and lot of cases with high-grade neuroendocrine cancers. But even extrathoracic or EP-NEC extra-pulmonary neuroendocrine carcinomas, they weren't as rare as I would have thought or read in the literature, and there were no treatment options. So today we have a fantastic agenda lined up for this podcast on this very understudied, under-talked topic, but it is very impactful for the patients, and it's unfortunately a very aggressive disease with still very poor outcomes. However, there is a ray of hope, and we'll discuss that. Before we delve deeper into the nitty-gritty, let's first understand what high-grade neuroendocrine cancers are. So when I see a patient who has been diagnosed with neuroendocrine tumor or neuroendocrine carcinoma, I first like to orient the patient that this is not a single disease. It's rather a spectrum of diseases. So neuroendocrine neoplasm is a general umbrella term, and they can come in different forms. The first dichotomy or the most important differentiation in different types of neuroendocrine cancer is based on morphology or how these cancer cells look under the microscope. And based on that or morphological characterization, there are primarily two types of neuroendocrine cancers. One is called neuroendocrine tumor. They are relatively slow growing as compared to neuroendocrine carcinomas or NECs, very fast growing, very fast paced disease. And some of these neuroendocrine carcinoma patients, the tumors can double in 2 weeks of time. So a very different disease altogether. So this distinction between NET, neuroendocrine tumor, versus NEC, neuroendocrine carcinoma, is very, very crucial because these are different diseases. They may sound similar, but they are very different diseases, different prognosis, different outcome, different type of scans, different diagnostics, different therapeutics. So that is very, very important. NEC can afflict many organ systems. It's not limited to just lungs or hepatobiliary tract, pancreas, colon, ovaries, cervix, you name it. I have seen neuroendocrine carcinomas from various organs, from larynx and head and neck region, etc. So it can truly afflict many organ systems. So one way to describe high-grade neuroendocrine carcinoma is based on the organ side. While small cell lung cancer is the commonest variety of high-grade neuroendocrine carcinoma, as I alluded earlier, together, all these other smaller subsets, if you combine them as extra-pulmonary or outside lung NECs, they do form a substantial number of patients who are a critical unmet need, and they are in need of therapeutic advances. And they affect patients young and old and from all walks of life. So organ system wise, we can segregate them between thoracic or pulmonary versus extra pulmonary neuroendocrine carcinomas. The behavior, however, is very similar, and that's why most of the treatment are very similar these are very aggressive and very fast-paced type of cancer, so you have this sense of urgency. So that would be a good pivot to Susan. How have your experience with dealing with this disease, and how do you, when you interact with the patient, what is your experience like? What are they going through, and what do you kind of guide them at the beginning of their journey?
It depends when the patient finds me, and that's exactly what happens. They find me and the group. When you get a diagnosis of this, when we got our diagnosis, there was nowhere. There were, 12 years ago, there was no group, there was no help. And comparing to an NET, that's what we didn't know the difference, and that's a huge part of all of this. And that is, in the one word that we use often, the word urgency, that's a huge part of the difference between NET and NEC. Many patients are told at the very beginning that they have neuroendocrine cancer. It's not specifically carcinoma, in which case they are then thinking, oh, this is okay. I'm going to be okay. They're not told the difference between an NET and an NEC. And it's honestly because a lot of oncologists, community oncologists, really aren't familiar with the difference and the aggressiveness of this. And I think that when people get this diagnosis, they go into a panic. I mean that is what I went through. You don't know what to do. You run to social media, and this is really where we come in, because I will talk to people from day one. They reach out to me. I talk to them. I educate them. But aside from that, it's the fear, the panic. I can't use those words enough, because it is something that you cannot describe it. I can't describe it to you, the feeling that I had when I heard this news. And I think that's a big part of the problem, getting to the right doctors and getting the help they need. They're not getting the help they need. And this is part of the issue of why I do what I do, because this group of patients needs help today and yesterday, and we can get them the help that they need and calm that panic and calm those emotions, because there is help. Today there is help.
To your point, Susan, I completely agree. Especially after 2017, things got a little bit more nuanced in our world. Previously, all grade 3 neuroendocrine cancers used to be classified as neuroendocrine carcinoma. However, we knew that wasn't
Mm-hmm.
true, because there are some patients who are very aggressive in terms of their disease biology and rapid onset of symptoms and progression, while others, despite having grade 3 disease, they are relatively slower growing. In 2017, WHO formally classified that there are two types of high-grade neuroendocrine
Yes.
cancer: grade 3 NET versus NEC, which is by default always grade 3. So to your point, you're absolutely right that there is a big, sometime a dilemma in terms of diagnosis when we see patients from places who don't see high volume, high grade neuroendocrine cancers. There could be sometimes discrepancy between NET versus NEC. And fortunately, things are evolving towards better as we are learning more and more about the disease, and also employing sometimes molecular testing in NGS and genetic testing to help us tease out differences between NEC versus NET. But you're absolutely right. That's one of the first issues. In my experience, another issue, as you alluded to, is the urgency of the matter. Once a patient has been diagnosed with a mass, and has been diagnosed and had a biopsy, and it's a poorly differentiated neuroendocrine carcinoma, oftentimes our diagnosticians or the colleagues, we are GI doctors or surgeons or whosoever did help bring the diagnosis to the fore, they don't realize this is a much faster, aggressive disease, and oftentimes patient needs to be staged right away and started on treatment ASAP because of the rapidity of it. A lot of times for NEC patients, we get them admitted and get them started on chemotherapy right away. It's not an unusual thing to do in our world. So that understanding of the urgency of how fast we need to deal with getting the clarity of diagnosis, starting the treatment is very, very important. And that brings to the third problem that when people try to learn about this disease, there are not very many resources online teaching them about NEC. And thanks to your society, Neuroendocrine Cancer Foundation, and others, they are slowly now focusing on NECs. You've been primarily focused on NEC to begin with, but even the other organizations are now trying to showcase the importance and urgency of NECs and increasing some educational guidance regarding that topic. But it's very important because patients can get confused. NET is a very different disease with different treatments.
I was just going to say that at times people will find me and they'll have all their work, they'll have their workup, they'll have their scans, but they're being scanned and treated as if they are an NET. And then when I'm talking to them, they don't understand because their physician doesn't understand. And who are you going to believe, really? You're going to believe your doctor. So sometimes people are very skeptical because they want to believe that this is something they can live with for a very long time. But, so there are times where I am telling people for the first time that what their physician is not telling them. It's an awkward place for me to be at times because they want to believe their doctors, and it doesn't happen. It unfortunately, I hear stories that I could write a book about that of the misdiagnosis, the mistreatments, the scans that are wrong, the testing that is wrong. So it is so important.
In my experience, things are slowly but surely improving. There was a time I used to, for example, see patients getting dotatate PET for NEC diagnosis, where we know
Yes.
an appropriate PET scan would be FDG PET, whereas for a well-differentiated neuroendocrine tumor is when we will be doing a dotatate PET. Those things are slowly but surely improving. I am seeing a better
Yes.
understanding of NET versus NEC in our colleagues. Um, and that brings us to how do we manage these patients? How do these patients first present with? Well, EP-NECs or extrapulmonary neuroendocrine carcinomas really oftentimes presents with significant weight loss, and this is unintentional weight loss. And based on whatever organ site is affected, patient oftentimes presents with symptoms. For example, if it's a rectal neuroendocrine carcinoma, they may present with blood in the stool or intermittent diarrhea, constipation, or pain. If it is neuroendocrine cancer affecting the cervix or gynecological organ, they might have heavy menses or bleeding per vagina. So it really depends on what organ site is affected. So weight loss, pain being some of the common symptoms oftentimes, but many times patient may not have symptoms and they are diagnosed
Mhm.
incidentally. And that's what's scary about this cancer is because it doesn't give you clues while it's growing and spreading and creating a havoc. Have you noticed any commonalities between the patients that you often meet, how they present, and what is their presenting symptoms, and how do they approach the early phase in the diagnosis?
I can use my story for that because my husband, Larry, didn't have any symptoms. I mean, he woke up, he was perfectly fine one day, woke up hours later during the night with belly pain. And, you think it's an appendix. What could this possibly be? And then to be told an hour later that there are 90 tumors on your liver. When as a nurse and had a doctorate in pharmacy, worked for a pharmaceutical company for his whole career in oncology, when we got this diagnosis, as I said, he worked in oncology and he had never heard of this. So, no pain, he had no symptoms. And it was very scary to know that he had all of this disease in him. As it turned out, it was in every bone, it was everywhere. And we had no idea. And often I hear this, oh, but I feel so good. I run, I eat organic, I do keto, I do all these things, I do supplements. And, so I can't really be sick, but, this is more, I hear more of that than I hear of people, being admitted with symptoms that they don't know what are. I think that's more in the NET world where they suffer with chronic symptoms for a long period of time. That typically isn't the case from what I've seen with neuroendocrine carcinoma patients.
Yeah, it's the rapidity of symptoms and such acute presentation. All right, let's switch gears and talk a little bit about treatments. Now, as I alluded to earlier, EP-NECs or extrapulmonary neuroendocrine carcinomas oftentimes are treated akin to small cell lung cancer. That's one of the commonest type of neuroendocrine carcinomas and probably the most studied in terms of clinical trials and data. So oftentimes we use the treatments paradigm extrapolated from small cell lung cancer. However, there are subtle differences and nuances between small cell lung cancer and EP-NEC. As Susan mentioned, many times there are no risk factors in EP-NECs. It might be a very healthy patient with healthy lifestyle and out of blue develops EP-NEC. Small cell lung cancer, unfortunately, is a very tobacco and smoking driven cancer. So right off the bat, there are different causations or the factors that might be linked to these different diseases. Secondly, EP-NECs, many of these could be large cell neuroendocrine carcinomas, some could be small cell. And when we take a deep dive into the molecular genetics, they're very different than small cell lung cancer. So small cell lung cancer almost always have the classic mutation in TP53 and loss of RB1. But when we are dealing with the EP-NECs, extrapulmonary neuroendocrine carcinoma, it's not that majority of patients will have this classic combination. In fact, only half of them might have it. So again, it's a very heterogeneous disease and may behave very differently. However, because of the paucity of treatment options, we still sort of rely on our small cell lung cancer regimen. And we've been using a regimen called platinum doublet since 1980s, carboplatin etoposide, cisplatin etoposide. And for many patients, it does work very well. Unfortunately, the effect is short-lived. We are talking few months to several months, but not years for sure. Susan, how's your experience with what kind of treatments are offered to the patients? Are treatment even offered or not? And what type of prognosis is painted when patients first meet their providers? And what is your general sense of what patients get treated with initially?
Initially, they usually get platinum and etoposide. I've seen some, if there's a mixed, a MENEC, obviously they start with something like FOLFOX. But generally speaking, that's what it is. And this is part of, being the ability of what I do, bringing people together so that they can share their experiences and share their side effects, whether it's platinum or FOLFOX, or now we have so many new options. For me, looking in from 12 years ago, the landscape is so completely exciting, that all these companies are finally looking to DLL3 and other targeted treatments. It is amazing to me, and I'm just so thankful to you for the work that you do. But yeah, I think that people tolerate chemo pretty well. They don't allow themselves to get bogged down by side effects. They live with this disease. And again, I think it's the support that they're getting while they're doing whatever treatment they're doing.
I completely resonate with that point, Susan. I think we've made a lot of progress in terms of treatments we could offer 7 years back versus now. And while we all understand that we are dealing with a very aggressive disease with historically very poor outcomes, we are seeing more and more cases that are responding well to some of these novel therapies.
Yes.
And as compared to 7 years back, we would rarely talk about third line, fourth line, or fifth line treatments. These days, when I meet our patients, we start with standard chemotherapy, but then very soon get into novel and promising drugs under clinical research. Then with DLL3 bites, we will talk a little bit about it. That seems the most promising of the lot and the most advanced in terms of new drug development. But there are other radiopharmaceutical drugs. These are targeted radiations, immunotherapies, oncolytic virus therapies. So a lot of progress is currently underway with DLL3 bite sort of leading the charge. I'll give you a quick anecdote with my foray into this DLL3 bite in NECs. And so I was part of one of the phase 1 trials, and one of the patient's daughter found our clinical trial on clinicaltrials.gov and found me. And she was pregnant, had in her third trimester, and she her request was, "Doc, can you do something that my father can see his grandchild? Can you just give him additional 3 months?" However, I really wanted that patient to try something, and it's already been through 5 standard lines of treatment. We tried this DLL3 by drug, and lo and behold, I mean, when I left Kentucky 2 years later, that patient was in near complete response and traveling around the world and had a great quality of life. So those kind of advances and outcomes we only see with immunotherapies. I almost never see those kind of results with chemotherapy-based
It's
drugs.
true.
But in my world, where I focus on EP-NECs, I'm very excited about obrixtamig. That's a DLL3 bispecific T-cell engager drug currently under investigation at Darien 5 international clinical trial. And there's already a lot of data discussed about this drug from phase 1 studies and different meetings. And it's looking very promising, especially for patients who express high DLL3. Again, it is still under investigation, and we're going to yet to see how it all pans out. But at least there is hope and optimism. Previously, as you mentioned, there were just no drugs under development. Now, at least there are drugs that may not benefit everybody, but if it benefits a significant amount of people, that is a big game changer for all of us in the field.
You mentioned hope. I just wanted to go back there for a minute because up until probably 5, 6, 7 years ago, there really was no hope. And I couldn't offer hope when I would talk to people. Today there is hope. There is so much hope in it, and that, if nothing else, it is just amazing because people are living. People are living with their disease. It's amazing to me that we still are getting people that are living longer and longer.
Yeah, a lot of progress and still a long way to go. We're nowhere even close to where we want to be. But these cases where patient had exceptional response and they're going years on novel immunotherapies, bite therapies, and other treatment strategies, it gives us a lot of hope, not just for patients, even for doctors like me, that yes, we need to continue to strive and develop new treatments. And we see these incremental improvements over years and decades in our field. Thank you, Susan. So let's summarize this wonderful conversation and podcast focusing on ECs for our audience. Unlike neuroendocrine tumors, EP-NECs, extra-pulmonary neuroendocrine carcinomas, are poorly differentiated, are high grade, are very aggressive, fast-growing cancers, and unfortunately have poor prognosis. However, there are a lot of very promising treatments in the pipeline right now, especially DLL3 targeted T-cell engager therapies like obrextimab and several others in development right now, offer a lot of hope to our patients who are in dire need for improvements in the therapies. Access to a patient support group like the one Susan has and several others are focusing on high-grade neuroendocrine carcinomas, very crucial to help patients and caregivers navigate this very treacherous journey. Thank you so much for listening in and tuning in. Thank you, Susan, for your time and spending your valuable time with us in this beautiful conversation.
Thank you, Aman. I appreciate the attention being focused on high-grade neuroendocrine carcinoma, or EP-NECs. It has really been a dream of mine that this could happen someday, and that the work that I started to do to help people who were so confused 12 years ago has become, my mission to personally get involved with patients that are newly diagnosed. That is what Minka's Nets mission is about. It's about helping people personally and staying with them for whatever their needs may be.
If you enjoyed this podcast and want to find out more, then please look for the Oncology Medical Conversation podcast under the account of Core2Ed Medical Education. Also, don't forget to rate this podcast, subscribe to our channel, and share it with your colleagues. Thank you for listening, and see you next time. This podcast is an initiative of Core2Ed and developed by Net Connect, a group of international experts working in the field of neuroendocrine tumors. The views expressed are the personal opinions of the experts, and they do not necessarily represent the views of the experts' organizations or the rest of the Net Connect group. For expert disclosures on any conflict of interest, please visit the Core2Ed website.